So it's really our great pleasure to have Dr. Arthur Wilde with us today. And we are very sorry that this technical issue cannot enable his video at this moment, but believe me, he looks very handsome, as you see on this slide. And he is the most respected cardiologist in the Netherlands, in Europe. It's with extreme expertise of inherited arrhythmia, heart failure, in general arrhythmias. And it's really our great pleasure to have Dr. Wilde with us, who will be speaking about some aspects of genotype-phenotype association in long QT. Arthur will be happy to have your slides. I will stop sharing mine. And again, we're sorry that we cannot see you, but at least we will hear your voice.
Thank you very much, Wojciech, for your kind introduction and your kind words. I assume you can see my slides.
Yes, thank you.
Yeah. It's actually quite nice to see the room where Ilan is sitting, because that's the very same room where Dr. Moss and I wrote this LQT3 paper that you just mentioned. So it's a pleasure to speak to you today, and the topic I was asked to address was the genotype-phenotype associations in long QT syndrome. And there are two words that need to be explained. Genotype is the underlying genetic basis of the long QT syndrome a patient might have. And the phenotype is what we refer to if we speak about disease expression or disease characteristics. And so the question to address or to discuss now is what do we know from genotype-specific phenotype associations? Does the phenotype influence the phenotype? I have a few introductory slides on the long QT syndrome, which might be familiar to you, but I thought I'd start with that. So before 1995, the long QT syndrome was an inherited heart disease. It was known as an inherited heart disease and associated with arrhythmias. Most often in those days, we believed, and I think that's still the case, although Dr. Zoriba just showed that elderly are also affected, but children are definitely most often affected. And beta blocker therapy is mostly effective, but not always. And after 1995, it was the genes that were associated with long QT syndrome were recognized, and it became quite complex in these early years because the disease proved to be heterogeneous, which means that more than one gene is involved. In different patients, different genes are involved. And the number of different genes went up to almost 17, but in very recent years, it was brought back to 8 with a definite association. So there are 8 different genes that are associated with long QT syndrome, and the other 9 have some limited or disputed evidence. If you start genotyping in a patient with a definite diagnosis, then in about 60% you will be successful. And there are definitely, and that is what I'm going to discuss in this talk, gene-specific features. And we know that from type 1, 2, and 3 because they are the most frequently occurring. The other ones are rare to very rare, so it's less known in these other subtypes, but I will mainly discuss on type 1, 2, and 3. The prevalence of these different genotypes is in this order. Type 1 is about 50% of patients. Type 2 is about 35% of patients, although it might differ from country to country. In my country, the Netherlands, type 2 is more frequent than type 1. Type 3 is about 8 to 10%, and the other subtypes, as I mentioned, are rare to very rare. The underlying problem, the genes that are responsible for these diseases, for the different subtypes of long QT syndrome, are encoding for ion channels. A gene is encoding for a protein, and the protein involved in these diseases is an ion channel responsible for the electrical activity in the heart. And type 1 and 2 are potassium channels, responsible for the outflux of potassium from the cells into the outside environment. And type 3 is the sodium channel. And this is a figure, a cartoon of a potassium channel. It's a protein that is in the cell membrane. As you can see, this purple thing is a protein. This is a cell membrane, and these green circles are potassium ions, and this protein is able to transport potassium from the inside to the outside. And here are different channels. This is the cell membrane. This orange part is the cell membrane. There are many different potassium channels, and 2 of them are involved in the long QT syndrome. There is a sodium channel and there is a calcium channel, and they are transporting sodium and calcium into the cell, and the potassium channels transport potassium out of the cell. This transport of ions leads to cellular electrical activity. So on the cell basis, you can measure this type of signals. And all these signals from all the cells in the heart ultimately translates to an EKG, which is measured on your body, on the body surface. And if these signals become longer, as is the case in long QT syndrome, that is translated into a long QT interval on the EKG. Now, this is the heart, a schematic drawing of the heart, and the electrical activity is following these green roads, so to say. It starts all here in the sinoatrial node. The electrical activity goes to the AV node, and then the ventricles of the heart, the chambers of the heart, are activated. And you can measure the cellular activity at the body surface by EKG. And this is one lead of the EKG. And as you know, if an EKG is made, there are many buttons on your body, and altogether they make this electrocardiogram, which has 12 leads. And this is a normal electrocardiogram with the 12 different leads. The signals are different because you look from a different angle to the heart. And this is a normal EKG, and the abnormality in the EKG, as you see in a patient with long QT syndrome, is here. If I go back to this EKG, this is the QRS complex. This is the spike here, as Dr. Zariba already showed. This is the T wave, and the QT interval is from the beginning of this QRS to the end of this T wave. And in this patient, you start here, the QRS here, you end there, and then it's clear that this is much longer than in the previous slide. This is the sign of long QT syndrome. So the symptoms of long QT syndrome are dizziness and syncope, and in the worst case, sudden cardiac death that is initiated by a syncopal event. But if the patient does not wake up, he might ultimately die. And sometimes it is diagnosed as epilepsy. That is actually then a wrong diagnosis. The syncopal events are regarded as epilepsy, but in a patient with an abnormal EKG, the diagnosis of epilepsy is probably wrong, and it then should be long QT syndrome. This is what happens on an EKG during a very short episode of dizziness. This is a clear abnormal EKG signal. Here's the normal signal with very long QT intervals. And here the heart rate is very high, above 200. It lasts for only 2 seconds, so it's most likely that the patient might not even notice or just notice a slight dizziness in this particular case. But if it lasts longer, as you can see here, this is almost 10 seconds, this might definitely lead to a syncopal event, a short syncopal event, which starts somewhere here after a few seconds, and a few seconds later the patient will wake up when the arrhythmia has stopped spontaneously. But if the arrhythmia does not stop spontaneously, it might lead to serious trouble and ultimately sudden death. So I mentioned the 2 potassium channels involved in LQT type 1, LQT type 2, and the sodium channel in LQT type 3. Now, there are gene-specific features. Dr. Zariba has already mentioned a few. There are typical EKGs. On the basis of the EKG, you can give a good estimate whether the patient has an LQT type 1, 2, or 3. There are definitely event-associated triggers, and that is important for lifestyle measurements that I will discuss later. The age of onset is also different. In one of the slides that Dr. Zariba showed, it was clear that patients with LQT type 1, children with LQT type 1, are earliest in terms of age of onset. And LQT type 3 might actually a little bit later. And all that leads to different therapeutic choices that will be discussed later in this seminar. So this is an important paper also from the LongQT registry, the same registry that Dr. Zariba discussed, but this is the first author on this paper is Dr. Schwartz, who co-founded the registry with Dr. Moss 40 years ago. This paper was published in 2001, and this is on the triggers for cardiac events. So what was the patient doing at the moment he had a syncopal event? And the different subtypes are here, LQT1, LQT2, LQT3. And in blue, you can see that exercise, the patient was performing exercise at the moment of a cardiac event. In red, it is an emotional event. In yellow is sleep or rest. And some other triggers are in this light blue color. The first two, exercise and emotion, are both triggered by adrenaline, by adrenergic, that is an adrenergic cause. And if you add these two up, then what you get is in almost 90% in LQT1, the trigger for an event is an adrenergic event. So it's either exercise or emotion. In LQT2, it is in 56%, and in LQT3, it's only in 1/3 of the events. So that, and that I will discuss that later. Exercise is mainly in LQT1 something to take care of, and less so in LQT2 or 3. There are some specific triggers, very specific triggers that have been recognized. Swimming, and my personal belief is that this is most often diving, so it's diving under the surface of the water. If there is a swimming-related trigger, in this whole registry there were 105 swimming-related triggers, and 104 of them were in patients with, with the subtype LQT1. And that means that I think that diving, you have to go under the water surface before that is a trigger. That is a serious issue in LQT1. I think if you are treated well with a beta blocker, then that is not a big issue. At the same time, and that is particularly relevant in the country where I live, where there is more water than land, that everybody needs a swimming diploma. So also LQT1 patients do need a swimming diploma, but if you are well treated and under supervision, you can still swim and dive, at least to get your swimming diploma. But this is something to take care of in patients with particularly LQT1. Auditory stimuli, that is the alarm clock, for example, are most often found in LQT2 individuals. It is not that they are not found in LQT1, but it's only 4 out of 390 patients, but it's 43 out of 175 in LQT2 and 4 out of 57 in LQT3. So the alarm clock is an issue in LQT2 patients, but the same holds for a doorbell, and it's also scaring. If somebody is scared, suddenly scared, that is a particularly relevant trigger in LQT2. And patients with LQT2 or families with LQT2 should take care of that. They should not have an alarm clock like this, but a more gentle one. And you may also change the doorbell to a less noisy one. And scaring is something to be avoided. When it comes to sports, lifestyle measurements, when it comes to sports, as you may already have appreciated, that is LQT dependent. In type 1, it's particularly no swimming and no diving. We think that type 1 and 2 elite sport is probably something to be avoided. But at the same time, with medication, a lot is possible. There is a study from the Mayo Clinics where they have followed elite sport athletes with long QT syndrome, and they do all well on medication. But we are still a bit cautious with elite sport in type 1 and type 2 patients, and particularly when it's elite sport swimming, that is something not to be advised to patients with a type 1 LQT syndrome. And all this is obviously appropriate under appropriate guidance. When it comes to recreation, this is very similar. Swimming and diving is something to be avoided by type 1 patients, and certainly not when they are under no supervision. Amusement parks is something that is quite often asked, and I consider those things in an amusement park as scary things, or other scary things are probably also better be avoided. This is a good example of something that I don't advise my patients. This hyperloop, it's a quite a scary thing, and I think it's a don't for a patient with long QT syndrome type 1 and type 2. And these are two other scary things: bungee jumping, skydiving, etc. It's probably something long QT patients may better not do. When it comes to this recreation, there is a lot of variation between one patient and another, so it depends on experience. I believe if you are very scary in these roller coasters, then you probably should not do it. If you feel very relaxed, that is a different situation, and definitely you need to be treated before you experience all these scary things. And the more scary, the worse it is, and should preferably avoid. Travel is something that is frequently asked. I advise my patients preferably not to go to countries like India, where there's always food poisoning. I've been there myself 2 times, and although I had the fortune to be in very good hotels, food poisoning is around the corner, even in very good hotels. And that leads to potassium loss, and that is something that is dangerous, in particular to patients with type 2. Food poisoning also leads to vomiting, and so that you have no medication at that point in time. You might even have fever, and all that is added on top of each other, and that is not something which is very fortunate for a type 2 long QT patient. And malaria prophylaxis, if you go to countries in Africa, malaria prophylaxis has an issue with LQT medication that might worsen the QT prolongation. Energy drinks is something I will discuss in a minute, and food, in particular grapefruit, is not good for long QT patients, but that is not gene specific. It should be avoided by all long QT patients. Although the one study from Dr. Viskin in Tel Aviv, which is about this particular issue, these patients were exposed to a lot of grapefruits. It may not be relevant for just a single glass of grapefruit in the morning. Energy drinks is something that comes up from time to time. This is from CNN in 2017, where it was mentioned that a teen died from too much caffeine. And that was studied by a group in Sydney in Australia. And they studied the cardiovascular effect of energy drinks in long QT syndrome patients. The protocol is down here. You have the first drink here, you have an EKG. After 10 minutes, you have an EKG. After 20 minutes, you have an EKG, and you have a second drink, another EKG, and furthermore EKGs. So there were 2 energy drinks in this course, and the EKGs that you see are here. This is the QTC interval between baseline, which is before the first drink, and the maximum QT during all these EKGs. And you can see that some patients actually respond with very significant QT prolongation, and that might be at risk of arrhythmias at that time. The authors have not been able to link this to a specific genotype, so it's unknown why some patients respond so dramatic with QT prolongation and others do not. But in general, we believe it's fair to say that be careful with energy drinks, and certainly not more than one. Having said all this, I think at the same time it should be emphasized that with appropriate treatment, much is possible. But I think if you live wise and don't look for the problems, then it's probably you can have a virtually normal life. But some things should really be avoided, and that might, as I have mentioned, be determined by the genotype that is involved in your family. All this has consequences for treatment, but I already mentioned that will be discussed later in this seminar. Beta blocker treatment is the cornerstone of therapy in all subtypes, and its efficacy may differ a little bit between different subtypes. It's known it's very effective in LQT1, which is no surprise because the adrenergic triggers are most pertinent in LQT1, but it's also effective in LQT2 and 3. Sodium channel blockers are particularly effective in type 3, but also in type 2. And my personal belief is that they are not so effective in type 1, but that has to be proven. Left stelectomy, that is a surgical procedure that Dr. Zariba mentioned in the first paper of Dr. Moss, is very effective also in type 1 and 2, and maybe not so effective in LQT3. And the ICD will be discussed later, and particularly the moment of implant might differ between the different subtypes. So in summary, ladies and gentlemen, long QT, as you all know, is a potential serious disease. It is often, but not always, treatment is needed. So often treatment is needed, but not always. There are definitely genotype-specific features, as I've mentioned, and these have relevance for lifestyle. So the lifestyle advice may be different for the different subtypes, and it has also some relevance for treatment. Thank you very much for your attention.
Thank you, Arthur, very much. It was very nice summary of very important aspects, including lifestyle modification, which you stress so much. My suggestion is, Ilan, if you agree, that maybe we'll continue and we will do questions after everything. You agree?
I'm fine with that, yes.
You are fine. Okay, so let me therefore invite Dr. Ilan Goldenberg, who will be speaking about sex-related differences and oral contraceptives in long QT patients.